PEG stands for percutaneous endoscopic gastrostomy and describes one method used to create a gastrostomy. Other methods are surgical and radiological. This film looks at the endoscopic technique. PEG is an elective procedure and you'll need to know the indications, contraindications and relative contraindications when deciding which method of insertion for creating a gastrostomy is clinically preferred for your patient.
Hello, I'm Roger Lester, Director of the Endoscopy Training Centre at St George's Hospital in London. Since the availability of PEG tubes in the 1980s, replacing the more complex procedure of surgical gastrostomy, PEGs have been widely inserted. But it is very important to make sure that the indications of PEG insertion are correct and all patients are vetted by a professional nutrition team before proceeding with the procedure. We hope that this practical demonstration of PEG insertion will help support your practice.
As an elective procedure, it's important the decision to place a PEG is acceptable to the patient, family or carers. PEG is the least invasive procedure for creating a gastrostomy. The Nutrition Support Team, NST, and or Multidisciplinary Team, MDT, should meet to discuss each case. This should include an accredited therapeutic endoscopist. The team may also include a nutrition nurse specialist, dietitian, clinician from a relevant specialty with experience in nutrition, and a speech and language therapist. They'll decide which procedure is clinically suited to the patient and give their guidance.
So is everybody in agreement?
Yeah, definitely, yeah.
Patients, family and carers should also be given procedural information. And information leaflets are usually available from the endoscopy unit. For many patients, the procedure of choice would be endoscopic gastrostomy, or PEG. This is the least invasive and the tube used will be more durable and maintenance easier for patients and carers. Patients who can't have an endoscopic procedure will be referred for radiological placement or RIG. Surgical gastrostomies are usually performed if the patient is undergoing abdominal surgery. Some of the indications for PEG are stroke, multiple sclerosis, Parkinson's disease, other neurological conditions, Crohn's disease, burns, head and neck cancer, and cystic fibrosis. And the relative contraindications for PEG are patients who are acutely ill, patients with a short life expectancy, patients who've had previous gastric surgery, ascites, and gastric varices. Be aware of restricted mouth opening. In order to be able to insert the smallest size mouthguard, a distance of 20 mm between the top and the bottom of the incisors or gums on full mouth opening is required. If there are no contraindications to PEG placement, you'll need to get consent. If the patient is able to give their own consent, this will be obtained in the endoscopy unit. If the patient's unable to give their own consent, a consent form should be signed by the consultant in charge of their care and their carer or family, when that's appropriate. Consent will cover peri- and post-op complications, which may include bleeding, gastric perforation, gastrocolic fistula, or peritonitis. Next, the essential pre-op preparation will move to the ward, where the ward staff should complete the pre-procedure checklist. It's important for everyone involved in a procedure to be aware of this, to ensure that this work has been signed and documented. So once consent is given, swab for MRSA before endoscopy, FBC and clotting results should be available and taken 48 hours prior to the procedure. Also, the ward dietitian should be made aware of the intention of a PEG placement and be informed of the date. Here's a sample pre-procedure checklist from St George's Hospital in London. You'll have your own version. The endoscopy team should be aware of any potential problems relating to bleeding prior to the procedure to maximise patient safety.
We're about to start a PEG insertion. We've prepared the area. We have a 16 French core flow PEG tube ready, and we have a dressing pack out as well.
The CoreFlow peg is available in 3 sizes, 12, 16 and 20 French. The 16 and 20 French can accommodate a jejunal extension which can be placed on initial insertion or later if the patient's feeding route changes.
As you can see, we have some betadine and some extra sterile gauze. We have a 10 ml syringe which we're going to inject our long-acting anaesthetic with, a drawing up needle and an injection needle to actually put it within the abdomen. We also have some scissors so we can cut the tube after the procedure, and as you can see, we haven't put the peg tube onto the sterile area yet because we're waiting for the patient to come in and then we'll dispense all the products.
This is an 81-year-old lady who had a stroke nearly 4 weeks ago now and is making a good recovery of her motor function, but is unable to swallow and has had a nasogastric feeding tube for those 4 weeks, and as she has a good chance of recovery, it's reasonable to place a peg. So she's had very minimal sedation, 1 milligram of midazolam. I'm just checking my scope first, make sure everything is working. Okay, we're just going to pop the instrument in. Just following the feeding tube down. It's often quite difficult to intubate with the patient on their back. And so I tend to leave the feeding tube in and follow that down. And we'll take it out when we put the peg tube in. Okay, we're down into the stomach. Got quite a big hiatus hernia, actually. Right. So we do a full upper GI endoscopy first. There's no point in, although she's had no problems with her feed, we want to make sure there's no disease in the duodenum. That actually looks fine. Okay. So we'll come back now and choose a site just in the antrum and see if we can see the light up against the anterior abdominal wall. Okay, let's just have a little look. Difficult to see where it is. What I'm going to do is just actually palpate the stomach there. See if I can find an area where we get good indentation. That actually looks quite good, just above the umbilicus. So if you transilluminate now, can we see anything there? Yes, I think so. Right, transilluminate again.
Oh.
There we go. Okay, that's... Often you find when people have had previous surgery, it doesn't actually quite react as you expect. I'm just going to transilluminate once more. Yep. Okay, we're right up here. There. Okay.
Right, okay. Do you just want to move that away?
Okay.
Okay, I'm just going to clean the area. Just using an aseptic technique, going from dirty to clean.
So I'm just putting the snare down now, ready to get into position for the needle coming through.
Okay, just going to put the sterile dressing, the drape, so we can increase our field to work with. So I'm just going to inject the area of local anaesthetic.
It's important to keep the stomach fairly well inflated.
Okay, just
so that it's actually
scratch.
blown up against the anterior abdominal wall.
Just aspirating as I go.
Okay, there we go. It's the needle just coming through there.
Just a bit short.
That's fine.
Happy with that?
Yep.
What we're going to do is just put the scalpel through now. And this scalpel is actually the same size as the 16 French tube, so it only needs to go down once. And that's the right size for the tube. And then we get our trocar needle, making sure it lines up and and your thumb on the end of it. It's going to insert that in as I watch the screen.
By keeping plenty of air in now so that the stomach remains up against the anterior abdominal wall. There we go.
There it is, okay.
Okay.
Just going to
Open the snare.
pull back a bit.
Yeah, can you just angle it slightly?
There
That's
it
it.
is.
I'm just going to put the snare over the trocar now. Okay, close.
Okay, I'm just going to feed the wire.
Okay, I'm just going to hold that there. So
Through.
it's actually pulling the needle back towards me, and I'll wait for the wire to come out.
Okay, that's out.
Second. Open the snare.
Got it.
Close. I've actually grasped the wire now with the snare. I'm going to pull that back into the instrument and then withdraw the instrument. We'll pull the wire through with it. Okay. There we go. Okay. Good. Okay.
Okay.
Thanks.
I now need to put the tube itself onto the wire. Sorry, that one through. And open it up.
Okay, that's fine. Plenty of KY.
Oh, that, you can take that
Just
tube
take
out of her
that
mouth.
feeding tube out. Okay.
Just going to get that out first.
Okay.
Just taking the little tube out of your mouth now.
That's it. Well done. Okay, so I'm now going to lubricate the tube.
Okay, and we're just going to pull the wire until I hit the knot.
Okay, just a little bit of discomfort there. There we go. Well done.
Okay, just take the trocar out.
Plenty of KY jelly. And just feed the bumper in through the mouth guard.
And we just, when you get to the right end, if you don't pull too hard, and just watch so you can see the measurements on the tube. Okay, that looks
Okay.
good.
And we tend to check the position of our tube because one of the complications is the so-called bumper syndrome where the tube is too tight, and it's always wise to just check the position. It takes 2 minutes just to check the position of the bumper. There we can see our bumper there. It's not tight, just sitting nicely on the mucosa, which is absolutely fine. So we'll take the air out now, just to make the patient more comfortable. Okay, we're nearly finished there now. That's fine. Just take that air out of your stomach. I'm sucking all the secretions out of the esophagus as I come back.
Okay.
There we go, all done. Okay.
It's marked at 3. It's marked at 3
Marked
centimetres.
at 3. Okay.
Okay. So what we're going to do now is just cut the wire off so we can put the feeding connectors on, or the tube connectors on. What we don't want to do is deflate the sponge inside the tube, so we need to put the clamp on before we cut the tube itself to size. So if we just put the first bit on first with the flat bit, we have to make sure we don't put it flush with the skin. We want to leave about a centimetre gap between the skin and the connector to allow for swelling or any edema that might happen, and it can be checked again tomorrow. The second connector goes with the pointy bit down first. You need to hear an audible click when you put this on. Okay, and then you can put the clamp on. I think a common mistake people make is to make the tube too long. Obviously you want it short enough if you're going to remove it later by a traction method, but if it's too long, it does get in the way and can get pulled out. So I've got the clamp on, and we tend to cut it here, just around just before the last bit of writing. And we connect the Y adapter just by unscrewing it, making sure that is inserted fully onto where the corkscrew starts happening, because that balloon lumen needs to be occluded. Okay. Make sure it's all closed up. And then you can undo the clamp and just remove the drape. We're just going to take this off your tummy. Okay, so we'll check that again tomorrow. Check for any edema or redness, and we can readjust if we need to.
Immediately after an endoscopic gastrostomy, monitor GCS post-recovery from sedation, which can take up to 24 hours, and vital signs every 30 minutes for 2 hours. Then, every 60 minutes for another 2 hours, and 4 hourly up to 24 hours post-op. Pyrexia, tachycardia, abdominal pain, or hypertension may be indications of peritonitis and should be reported straight away. Don't disturb the wound for 8 to 12 hours post-insertion. The wound does not require a dressing. Observe the wound 4 hourly for redness, leakage, swelling, and signs of irritation. Contact clinicians, endoscopy, or your nutrition nurse if complications do arise. Monitor for signs of pain. Give analgesia as prescribed. Kneel by mouth and tube for 4 hours post-insertion. And continue with IV fluids if prescribed. NICE Guidelines 2006 state that the PEG may be used 4 hours after insertion, but your local guidelines may increase this time. The feeding regime usually commences with sterile water for 6 hours to reduce the risk of peritonitis. It's important to continue with oral hygiene for patient comfort. 14 days is a guide for a healthy stoma tract to heal, although you should be aware of any particular medical issues with each patient that may affect or delay the healing of the stoma. Once the stoma tract has healed, the tube should be gently rotated and moved in and out of the stoma tract daily to prevent internal overgranulation and buried bumper syndrome. This helps to ensure that the tube is free moving within the tract. It also allows for atraumatic removal if the tube requires replacement or removal. The tube position at the external fixator should also be checked daily to ensure that the tube has not migrated from or into the stomach. It also helps to prevent external overgranulation. To administer medication, the feed should be stopped and the tube flushed with at least 30 ml of water. All medications should be administered in liquid form. Patients should be in a semi-upright position for feeding to reduce the risk of aspiration. Within the first 4 weeks after PEG insertion, careful and thorough care of the stoma site is essential, and you can find out more in the next chapter. Some of the common issues you may encounter are blocked tubes, leakage from the stoma, breakages requiring spare parts. If the tube becomes blocked with feed and the blockage is obvious, massaging the tube at the blockage may help to clear it. Also, you can flush with warm water.
So if you flush with a push-pause, 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 push-pause technique, you create turbulent flow.
If these don't clear the tube, soda water may help. Alternatively, use the clog zapper, which is designed specifically for unblocking feed from any feeding tube.
So now we've reconstituted the clog zapper, we're going to put the quill on the end so that we can inject to the point of blockage in the tube. Then we can feed the quill down to the point of the blockage and then inject down just 2.5 ml, not the full 10 ml that's in the syringe. So we just inject in. So we've got some backflow there, so the clog zapper's got to the point of blockage and it's just sitting there. That's just displaced anything that's sitting in the tube above that point. Okay, so once we've injected that, we can take the quill out and cap off the end. That needs to stay inside the tube for at least an hour, and then we'll come back and try and flush it again and try and unblock the tube. Once this has been reconstituted, it can be kept for up to 24 hours, but obviously it should be labelled for that single patient.
Leakage from the stoma is sometimes an indicator that the external fixator is too loose, allowing gastric contents to escape. This can cause irritation to the stoma site and tract. So, if this happens, reposition the external fixator to ensure that there's no excessive movement of the tube in the tract.
Okay, so to loosen the external fixator, if you want it a bit loose to the skin, say it's quite tight, all you need to do is twist the top part and move it down the tube, and then the tube can be adjusted so the other part of the external fixator moves up and down. So we keep it about 0.5 centimetre away from the abdominal wall, clip the tube back in place, and then slide and twist until they clip together.
The external fixator, clamp and Y adapter can all be replaced if required.